Hello, everyone, and welcome to today's session. My name is Courtney Youngbar, and I am a moderator for today's session. I'm a senior analyst here at ASTHO, and today's session is Painting the Picture, COVID-19 Visualization Tools that Inform Policymakers and the Public. The goals for today's session include to highlight how COVID-19 may have changed the way our panelists have developed their products, strategies, and general approaches to their work, as well as to discuss how public health has changed during this time, and what the panelists see from a trends perspective, and what the future of public health may look like in the coming years. We have a great lineup of speakers for today. And to start off, we have Dr. Ellie Graydon, who is the founder and CEO of Talus Analytics and an associate adjunct professor with the Georgetown University Center for Global Health Science and Security. She leads an interdisciplinary research and development team that applies data analysis, modeling, and visualization to solve challenging problems at the intersection of policy, science, and strategy. Next, we will hear from Shoultz, who is the Esri Health and Human Services Technical Lead. Prior to Esri, he was a senior GIS research associate at the University of South Carolina Institute for Families and Society. He also spent 12 years at the South Carolina Department of Health and Environmental Control as a deputy director, informatics director, and GIS manager. Dr. Este Geraghty will also be joining you on his presentation, and she is the Chief Medical Officer and Health Solutions Director at Esri. Finally, we will hear from Alexis Madrigal, who's a journalist based in Oakland, California. He's a staff writer at The Atlantic and co-founder of the COVID Tracking Project. Previously, he was the editor-in-chief of Fusion and a staff writer at Wired. So now we will go ahead and hear from our speakers.
Hello, I'm Dr. Ellie Graydon. I'm the CEO of Talus Analytics, and I'm a research faculty at the Center for Global Health Science and Security at Georgetown University. Thank you so much to the organizers for the invitation to be here. I'm really excited to talk to you all and have this conversation. We've been doing a lot of work at Talus and at Georgetown to look at data integration and analysis, but also visualization for operational response, with a very specific focus on what needs to get done in the context of these events. Now, we've done a lot of work over the years as a field, especially in the context of emergency management, to understand how to use visualization from the outputs of highly complex modeling, for example, the hurricane models that are still written in Fortran, and understand and communicate that uncertainty and those outputs in a way that are immediately useful for operational decision making. Now, as the COVID-19 pandemic unfolded, we have had a whole new opportunity to understand how to apply these types of tools for communicating the data that are coming in terms of in the context of public health and infectious disease. So what I'll focus on here are a few examples of work that we've done since March to really understand and use and apply the data that we've had in the context of this particular pandemic. Now, we know that context is critical, especially when we're needing to understand new data and data that is coming in over much longer time horizons than we're used to. You know, hurricanes are sort of in and out, and the core response is often a week or two long. We're deep, heading into the second year of this particular pandemic. What you're looking at here are some quick snapshots from a state level dashboard from this summer, when a lot of state dashboards were still communicating data in single numbers, in cumulative numbers, even for things like confirmed cases, and still were often lacking key contextual information around things like change over time. And what a lot of this meant was that decision makers were overreactive to small changes in data or swings in data from day to day that didn't really provide information about how the event was unfolding over time. So what we've done a lot of work to do is to understand how to better adjust these types of analyses and this type of data generation and visualization to drive those tactical decisions. So in one particular example, we've developed a program called Health Pulse. This was in close collaboration with and funded by the National Center of Immunization and Respiratory Diseases at CDC. And what we've done here is we identified a series of data. And this is actually from a project that was starting 4 years ago, but with an eye to a pandemic influenza event. So as you can imagine, it stood up and gained a lot of speed early this last year. So what we're doing here is collecting a wide variety of data from almost 600 different facilities across the whole US, and we report those data on an everyday basis. Now, what's really important here is we don't report the raw data. What we report are alerts. Those alerts are translated from a wide variety of disparate data sources, differing between the facilities and from the different providers. And we've translated those into an apples to apples framework so that you can do a rapid comparison and know which facilities are having a bad day by their own definition and by their own determination. So we ran the statistical analysis. And so when we say a bad day, we're talking about a day that is worse. It's in the top 1% to 2% of bad days for this particular alert type. We have 7 different alert types, emergency department overcrowding, ICU facility overcrowding, but also things like power outages and evacuations. So what you're looking at here is a map that shows in black all of the facilities from whom we're seeing data and those for whom we have reports. Now, what's been really valuable here is that, one, because this is coming in from different data sources and disparate data sources, we're able to do a comparison between, for example, COVID-19 impacts and that of the hurricanes. So what you'll notice here is that on the left, we have data showing not only intensive care unit alerts and emergency department alerts, but then when Hurricane Laura hit, we started seeing these operations alerts. Now, this is the only system that we know of that actually allows an apples to apples comparison and shows these data all in one place. So we were able to identify those facilities that were under evacuation notices or had lost power during the hurricane and had COVID cases. And it's this intersection of data that derives the types of operational decisions that can actually change the course of an event. We've applied this same type of thinking to the policy environment. So how do we capture data about what policies are in place and which policies have been put in place specifically to mitigate COVID-19? Now, these policies are intended to change the course of the event. They're not just reactionary. This isn't just response context. And we need to understand how those policies are changing the policy environment to better understand what types of operations and response actions are going to be most effective. So what you're looking at here are screenshots from COVID analysis and mapping of policies. It's a public platform that you have access to. We've hand-coded over 30,000 policies at this point at the state and county levels across the US and globally. You can dive in and see what each of those policies are, but also really importantly, you can actually go in, see those policies in context of the event in any given state, and then evaluate the impact of new policy decisions by adding new policies and seeing how much difference those are going to make on the future of the event. So taken all together, what we're doing across all of these different tools, and are really looking forward to this discussion with you all, is thinking about how we use visualization and these types of data integration systems, especially when we're looking at a broad span of different data types to really guide not only the next phase of COVID-19 response, but also to be using these same tools to build long-term capacity and get better at the next stage of response. We need systems that translate disparate data streams for those key decisions. Those response decisions require integration from a wide variety of different types of data, as we've talked through. That includes not only data about the event and the response capacity, the people who are impacted, but also the policy environment. And we need all of those data sources to build upon and grow the next suite of surveillance tools that will help us anticipate the next event, understand what we're seeing when it happens, and then respond effectively. So again, very much looking forward to the conversation and looking forward to the next round of presentations. Thank you so much.
Hello, My name is Este Geraghty, and I serve as the Chief Medical Officer at Esri. Esri is a technology company that builds ArcGIS, the world's most powerful mapping and spatial analysis system. You've probably noticed that map-based information has been front and center over the last year, with the Johns Hopkins University dashboard inspiring thousands of public health dashboards to communicate situational awareness throughout the pandemic. In addition to dashboards, location-based data has been collected in the contact tracing process to better understand community spread of COVID-19. Location intelligence has supported resource allocation decisions like where to site testing centers and currently how to put vaccination venues in the right places as we move into surge, the condition where we have the increased supply of vaccine and broadened population phases waiting to be inoculated. In all of this, data has been key, and I see a few distinct trends that I think will forever change our health data perspective. The first is the need for real-time and near real-time data. Leaders in government and across the business sector rely on current information to make critical decisions. Second, it's clearer than ever that our data needs to be disaggregated and standardized if we're ever going to be successful in identifying and addressing disparities across our communities. Third, to manage the fast pace in the data world, we need to connect new tools to our existing data-rich systems of record. This will improve the speed of using data and ensure that you always have the most current authoritative information. Finally, we've learned that context is everything. Human movement, accessibility, local resources, or resource deserts all rely on geographic context to fully grasp the impact of the factors that matter. My colleague Jared Shoultz will dive into a bit of the technical detail and show you some examples next. Jared?
Thanks, Este. Throughout this pandemic, we've seen a spike in the uptake and interest in map-based display and spatial analysis of COVID-19 information. At Esri, we know our users were heads down responding, and they needed one single location to find data, apps, and resources to support their work. So we created the COVID-19 Hub featured on screen here. This virtual gathering location provided access to these resources while highlighting amazing customer examples like the iconic Johns Hopkins dashboard. This was relied upon for the most current data on cases and incident rates and a variety of other metrics. As a bonus, JHU shared their data as open data on the Esri Living Atlas website. This is the world's largest repository of spatial data. You all actually have access to tens of thousands of data sets in there right now. But getting back to the JHU model, this open sharing made it easy for analysts to use this data in countless apps to keep their communities informed. I don't think I've ever heard so many people talking about EpiCurves in my entire career. This dashboard quickly became the most viral-based application in history, with more than 4.5 billion feature requests per day and trillions of views since its inception. Authoritative health agencies like DHHS also stood up their own hubs, like the HHS Protect Hub. This hub provided context and data from a variety of official sources. Users could locate national metrics and COVID-19 community profiles, along with data reported directly from hospitals regarding utilization. How many people are sitting in ICU beds? And capacity, how full is each hospital? As well as information on therapeutics and testing. Which hospitals are offering monoclonal antibodies and which are offering remdesivir. We also worked on innovative healthcare interoperability initiatives like the Saner Project, where we partnered with the who's who in healthcare IT to demonstrate that data can be pulled directly from underlying systems like electronic health records and displayed geographically using ArcGIS. This approach relies on international standards like HL7 and FHIR to provide real-time insight into individual hospital operations as well as across the region, without requiring already taxed healthcare workers to key data into a separate system. This is the future. The overall pattern of using maps and dashboards to display COVID-19 statistics was repeated across all levels of government around the world by organizations to display data at any geographic scale ranging from a single address to an entire country. On screen, you see our attempt to catalog just a few of them for the US. Here in California alone, we found 18 different examples, with the one on screen embedding an infographic that pulled data directly from the Johns Hopkins dashboard just for California. There was a national desire to standardize state-level COVID-19 dashboards, so we partnered with the CDC to provide technical assistance to any state or territory that wanted it. At Esri, we also leveraged our cartographic expertise to create tools like COVID Pulse. This application provides a normalized view of case rate and death rate trends at the state and county level using spark lines. We also used World Health Organization definitions of the phases of a pandemic to color code each trend line. This approach not only provided a way to compare apples to apples, it helped the users understand if apples were good or bad without requiring a detailed understanding of the underlying statistics. In other words, it was intuitive. So far, I've covered data visualizations and communication methods using GIS. Spatial analysis also added value. One great example is something we call community contact tracing. When you include location in your interviews, you can move beyond the traditional understanding of person-to-person connections and start to gain insight into the person-to-person-to-place connections. This type of spatially enabled link analysis helps to uncover potential sources of community spread and prioritize response efforts. There's so much more that could be done with these tools. I've not even touched on the traditional GIS mainstays of site selection and resource allocation. At Esri, we're here to help your organization explore these possibilities and the value of location.
Okay, thanks, Jared. So as we look to what's next, I can't emphasize enough the importance of maintaining and using the geographic perspective to make decisions. The things we've discussed for COVID-19 response are also relevant to every other public health challenge, whether you're combating vector-borne disease, addressing maternal child health, inspecting restaurants, or fighting substance use disorders. You still need to collect data, analyze for disparities, make resource allocation decisions, and monitor your progress. And you can use these same tools over and over again to make the work easier. We expect that the next need for public health preparedness will be community health assessments to determine where is the new baseline after the crisis. And we have a solution for that process. And as you modernize preparedness and other systems with the funding that will finally provide more support for your work, we can offer the GIS tools, assist with planning and implementation of your location strategy, and help you train and build capacity in your staff, getting you to your goals faster.
Hello, my name is Alexis Madrigal, and I am the co-founder of the COVID Tracking Project. And I'm just here to talk quickly about our project and what we've learned and how it might help you think about the tech tools that you need to do data visualization. So for those of you who are not familiar with the COVID Tracking Project, we began as a volunteer effort, grew into a group of 30 staffers, 400 volunteers, and we compiled data from states and turned it into national numbers. We did interpretation, we did analysis, we ran a help desk that answered thousands of queries. We worked with states as well as the federal government to try to standardize the data sets that were available and to make more data publicly available. From your perspective, perhaps you could think about it as, we are the people who went to probably more state dashboards, county dashboards, national dashboards, and web pages and pulled numbers and analysis from them. We are super users of these tools. We gathered in the end 800 data points each day, and that oftentimes required going to a multitude of web pages and doing various other kinds of calls to APIs and other things so that we could gather the data points that we had. We officially stopped data collection on March 7th, but continue to do analysis and accountability work. But those are sort of the basics from how our perspective came to be. And that is, all the tools can do the job. I'm sure that there are things about the tools that make one or the other better for your particular situation. It's not really my business to tell you what to do on that. Our perspective is really slightly different, that what's important is not just the data visualizations. And in fact, maybe the data visualizations are the least important aspect of what it is that you're doing. And if I were looking at a software package, I would want to know, how does this software package allow me to contextualize the visualizations and data that I'm presenting to the public? And let me tell you what I mean by that. For one, we all know that COVID data pipelines are messy. They're imperfect. There are weird backlogs. There are spikes. Things happen, for the CDC to a local county. Those things have to be noted. In fact, the caveats are as important as the data in terms of interpretation. I'll give you an example. Just last week, there was a backlog in the state of Alabama, and many news agencies ran that there was a 90% increase in cases in Alabama. Now, Alabama had noted it on their dashboard, et cetera, but when you have a big backlog like that and you have big problems, you need to be able to run with a big banner on that kind of stuff. And I think that's really important. So number one, figure out, how does this package help me caveat the data as well as display it? Number two, there's a lot of defaulting to maps. Just because data is geospatial doesn't mean it needs to be put on a map. And in fact, in many cases, the most useless COVID visualization that exists is a cumulative map of states or counties or whatever. No one cares. No one cares about the cumulative number of cases that occurred, especially because we know that we missed vast numbers of them in the springtime because we were under testing. So doesn't need to be put on a map, which means maybe at least a big chunk of what these software packages need to do for you is provide other ways of displaying information that isn't just a map of your counties or of a state or whatever it is. Third, we have noticed in interacting with lots of counties as well as national agencies, federal agencies, that there's rarely an opportunity to work with the public help desk. I would want these tools to have good reporting tools so that if somebody encounters something that's weird in the data or in a particular visualization, they can get in contact with us. And in fact, we ran a help desk at COVID Tracking Project that literally answered thousands of questions, usually about a state's data, not even so much about our presentation or capturing of that data, but just what happened in a particular place on a particular day, and why does the data look like it does? And I think what we learned about that is, while at times it was overwhelming, a help desk helped us as much as it helped our users, because it pointed out things that were confusing, it pointed out things that didn't make sense, and that allowed us to improve our visualizations through time. It created a sort of virtuous circle. The better job we did explaining and caveating and creating these visualizations, the less inquiries we got about that particular thing. And the more that we got allowed us to say, okay, that's a problem area. Last thing, we'd really love to see more user research and just a general orientation towards users. Many of the websites that we've seen through time have been designed by epidemiologists for obvious reasons. They are obviously important users of this data, but in something like a COVID pandemic, they're far from the only users. And so it really makes sense to us in evaluating these software packages, like, are there sort of multiple modes of presentation for the most experienced users who are used to looking at this kind of data, who are used to looking at epi curves, all the way to just like somebody who's checking in for the first time because, they just, hard to believe, but 10 months into the pandemic, they've decided they want to go to your website, or, a year, God, 14 months in, I don't know, however long we're in. And so just working with people to find out what they actually want, so that you can export the right things from these packages and this software. And, our final sort of plea is, to the extent that you can, make sure that you can make this data downloadable, make it available. We encountered so often on state dashboards that we had to hover over individual numbers. We had to, our screenshotting apparatus, which screenshots all 800 data points now, was so incredibly intricate and complicated because we couldn't just hit download on this data. Like, if you've got it on a dashboard, it should be downloadable, the end. And make sure that all these software packages would have that ability. Really looking forward to questions from the group, and really glad to have joined you on this particular panel. Thank you so much.
Thank you to our panelists for those great presentations. Now we are going to go ahead and start the Q&A portion of this breakout. To ask a question, please hover over the bottom toolbar to find the Q&A button and type in your question there. So to get started, and while we wait for audience questions, I'm going to ask a question. So this is for Alexis, but Ellie and Jared, please feel free to also chime in. So Alexis, you mentioned during your presentation, there are multiple ways of displaying and visualizing data. What are some of your preferred methods, or what other visualizations do you recommend?
Yeah, I mean, we got a lot of value, and I think lots of people got a lot of value out of just simple time series. You know, Ellie showed some of those, and just the difference between that and showing these kind of cumulative numbers. We created what we called like the sort of 4UP, which allowed you to put, you know, sort of tests and cases and hospitalizations and deaths kind of all in one image, and sort of giving you the sort of sweep of the pandemic. So you can kind of go a little bar chart blind after a time. I think we're always conscious of that as well. But I think that became a, you know, just a basic tool in the toolbox. And as it turns out, like for many different kinds of COVID data, it's turned out to be really important to be able to do that. I think most people on this call probably know that, though.
Yeah, you know, I'll kind of follow up on that a bit. Dashboards were mentioned quite a bit, you know, in every one of the presentations, and they become kind of part of the vernacular now. But GIS provides a lot of ways, and there was actually another question that I answered in the chat window about concerns related to, you know, privacy and you know, security, individual data sets. And, you know, there's so many different ways to display the data. I like bivariate maps, you know, like the COVID pulse, which puts information in context. But, you know, I like even more doing things like hotspot analysis, and emerging hotspot analysis to look at not just where problems are at right now, but where problems were in the past and they're going away, and where new problems are coming on board. I mean, if we're only looking at what's happening now, we're not ever going to get in front of what's going to be happening. So, you know, there's a lot of great ways to visualize data. And there's one thing that I've found is that everybody consumes things in a different way. And I really appreciate Alexis' comment about if the data's in a dashboard, it should be available for download so folks can visualize it in different ways, mesh it up, run their own analytics.
I think the only piece that I would add there is thinking about how the data are going to get used. Who is the audience? What actions are they needing to take that they're ultimately going to use this information to go drive? And how does that tie back to the concrete operational requirements that they're engaging with at the moment?
Great, thank you. Ellie, I think this question is for you, but Alexis, Jared, once again, please feel free to chime in. So the question is, how would you recommend statistical context is communicated with the data? Is there a way to visualize the context?
There's been some really interesting work done on how statistical variance and how uncertainty can get visualized in a way that a lay audience responds effectively to it. Whisper charts tend to be pretty bad, or whisker charts, excuse me. And you know, that I think what we tend to focus on is pulling forward, like I said, that action item piece that says, regardless of where your uncertainty lies, we know that it's going to be here, and therefore action is here. So aligning the data against a threshold, for example, for decision, so that you're not masking the uncertainty, but focusing on the action item driven by the information that's being presented. So it's less about showing all of the detail and more about showing where the breakpoints would be, you know, sort of where you're seeing big transitions in the data, or and then amplifying where there are sufficient differences that you do have a different action. So I think that's the big thing that we've learned is surfacing those action items, because then you're not overemphasizing the uncertainty where you may not actually have even enough resolution about what the uncertainty is. And that happens a lot, especially very early in events when we don't have great data coming in yet.
I I take all those points and think they are great. I think for us, you know, the specific focus of our work has oftentimes been explaining the anomalies, because there just have been so many through time, and a lot of it has to do with just, you know, you got death certificates back up and then they're going to come out, you know, later. And it's really important, I think, for the general public and decision makers to kind of both understand both sides of that, like, you know, as an outbreak is sort of very hot, you're probably underreporting deaths and you're probably going to get like another bump of them on the other side. But that doesn't mean that the pandemic in that particular place is worse when those deaths are being reported. It just means that they're sort of reporting lag. So we've always tried to like get across the context around how those data pipelines are imprinting or shaping the data. And I think, I really do think that's something that after this pandemic, there's probably some good research to be done into that and into how that information was received. And, you know, I think the public does in fact change its behavior based on death reporting. And so if that's the case and we have deaths being reported way after the fact, there's some like really tricky kind of ethical problems about that data pipeline, I think.
Just building really quickly on what Alexis just said, the only other piece here is that doing things where we look at where there is the greatest uncertainty. So for example, in that last 5 to 7 days, often there's a significant drop because they simply haven't been reported yet. So reporting the data as a 14-day moving average. So, you know, relatively straightforward sort of quantitative analysis on our part, but the answer that then is being reported is reflective of that overarching trend without emphasizing or sort of overemphasizing where we just aren't certain yet. So I think, yes, and there are these sort of mechanisms to do that as well.
And I just add one thing that became really tricky about death reporting, at least as we saw it, is oftentimes, you know, after a big surge, sometimes deaths were being reported like, you know, you're many weeks, you know, we're talking like 40 days in some cases, where you've got 25% of deaths being reported, you know, more than 40 days after they actually happened. And so some of those things were, because I totally agree that averaging things helped to kind of smooth out a lot of that stuff. But then the deeper we got into the death reporting, the more that we became concerned that we couldn't really account for it well until it actually showed up in the data.
Yeah, you know, I mean, I was over all the technology for a statewide vital records program for many years. And so I really appreciate Alexis's comments about, you know, not just like confidence intervals, but, you know, provisional data, residence versus occurrence data. Folks just don't understand why a mortality and morbidity report isn't released till a year or two after. But once you understand the process, but it's very hard to communicate. So it's not just, you know, the confidence intervals, it's that context behind the data that's important. And, you know, what Ellie said, I really like too, is like, what's the goal? You know, what's the, like, maybe not for COVID, but for, look at healthy people 2030. Look at what the goal is for low birth weight. Look at what the goals are and see where you're at to get to the goal, so that, you know, people know where the, you know, the finish line is at. Although we're not ever actually done with improving health outcomes, but, you know, giving people kind of a goal to get to.
Great. So our next question. I also appreciated Alexis's comment about making dashboard data downloadable. Often those data are already second or third hand, coming from hospital systems, public health agencies, etc. How can we move the conversation upstream to ensure sufficient data are made available in a timely manner, but also consistent with health privacy regulations? Public health interoperability, I can never say that word, hasn't been incentivized like in healthcare.
I'll take that one first, since I have kind of ran like the meaningful use program, you know, and to start reporting in directly from these underlying systems. And one of the things I mentioned in my talk is the work around HL7 in fire. And there was a specific, you know, process called SANER that really looked at culling that data out of the underlying systems, of course, having a kind of a review process, but making it more accessible from the systems of record without requiring secondary reporting, you know, so that you really get access into the EHRs, the death registration systems, the bed monitoring systems, and the asset tracking systems, so that you can get that information to people that need it without burdening the people that are trying to deal with the frontline issues around healthcare.
I can certainly speak to how we've done it, but I'd love to hear your thoughts on this too, Alexis, given how much time you spent looking at all of the other dashboards and trying to collate those data. Our approach at least is to look at, again, how are those data going to be used? And this ends up being really relevant because most people don't need all the data. In fact, virtually no one person needs all the data. And so it's this matter of defining what the requirements are for a specific system or for a specific type of information and surfacing only those metadata and those data that are directly relevant to that issue. What that allows us to do then is also aggregate up to the right level of resolution, highlight where the interest is for a specific use case, and then surface the raw data source for those end users, so that you highlight, for example, with thresholds, where the big issues are. You can do that aggregation. You don't have to give away the proprietary data, the privacy data. You can flag the issue and then allow somebody to go back with the appropriate permissions and do the double click to go deeper and go look at what they need. So what it's sort of doing is saying, well, instead of going straight to a data lake and saying, well, everybody needs access to all of the data in the system, it says, here is the thing that matters to you, that surfaces at a glance, and then you can go back to the actual source and go find out the thing that you really need. And so that's at least one of the ways that we're starting to think about this problem a lot.
Yeah, and it's rarely the individual point of data that is important. It's the patterns that the points make. And there's all sorts of ways to protect privacy and security. We've touched on quite a few of them here, aggregating across geographies, across time, aggregating up to different geographic units of analysis, and some of the other methods that I talked about. So, I think a lot of times, maybe concerns around privacy and security or hinder data sharing because it's such a complex field to navigate. But public health professionals don't collect data in registries to not use it to make better decisions. They want it to be used to make better decisions. It's just navigating that whole MOU, data use agreements process, who has access to what. It gets a little bit challenging. And if one thing has been true throughout the last 14 months is public health workers have plenty on their plate right now.
Yeah, for sure. I think our perspective would probably be slightly different, just in the sense that for us, fairly coarse data, I think for like the nation, given the sort of main users of our data were a lot of newsrooms and sort of high level policy people and things like that. People wanted to know just kind of what the basics of what was happening, right? We're not like supporting the response in the way of like, okay, somebody needs like more PPE at a hospital, or like there's a really severe outbreak in El Paso, or like, we were better and better suited to sort of understanding the larger sweep of things. And I actually think that's what most people wanted. I think most people wanted to sort of say like, is it better or worse now than it was a little while ago? Is it better or worse here than it was, in the places nearby? Like that's a lot of, I think, how people were sort of factoring their own decision making. And then kind of like Ellie was saying, but almost as a, almost like philosophically, then they could sort of like click into the deeper information that they needed from their county health officials or whoever it was. But it was also, we found that a lot of like situational awareness was really lacking, particularly for state officials. And so we found a lot of different kinds of state folks who were using our data in various ways, even if they didn't really want to, which was understandable. And so I think that coarser situational awareness kind of user is a big user, and also has like a slightly distinct set of needs from people who are more directly involved in the response.
Great, thank you. Next question. Furthering our challenges is that one has to look at multiple data elements to see what big picture is telling us, so trends, and what interventions are called for and when. How do you visualize multiple data elements to paint the big picture?
I'll jump on that first. I figured Ellie was probably going to jump on it, since she did have the trend line where she was overlaying multiple different elements on there. This is a big big issue. You know, I mean, we've seen, and it kind of aligns with some of the other questions, is it's not one data point that you need to look at. You need to combine it with a bunch of other ones. So we had a lot of our clients running, you know, predictive analytics models with the underlying case data, but then overlaying other type of data on mass policies, on social distancing policies, using human movement data to try to provide the context, and even using that data, looking at the outcomes to predict, you know, some agent-based modeling from groups like epistemics to see what's happening, you know, now, what's happening in the future, how are policies impacting things, and trying to look at, rather than look at things in isolation, looking at them together to try to get the big picture. But you kind of get to cognitive overload when you start putting too much of that stuff in there, and it's hard to make sense of it. So you got to be really careful about kind of how you design, you know, your interfaces and what you present. I mean, are you presenting for a team of biostatisticians, or are you presenting for the public?
I mean, I think a live area of concern here, I know for a lot of different people, is how we end up presenting these variant of concern kind of genomic surveillance data against the other kind of data types that people have become familiar with. So far, I haven't seen, I know, you know, there's maybe 25 states, something like that, that are providing variant of concern data on their dashboards, but it's right now not integrated into sort of the rest of stuff. And I would say the same is true at the national level, as well as with most of the outside providers of that kind of genomic information. So that one, you know, it's something that we're working on with another group and really trying to think through, like, how do we actually show this really quite complicated data over here and this quite kind of simple data over here, and the relationship between them is also complex and influenced by many factors. So there's, I think that's one of the hardest things about this entire pandemic data problem is, like, we would love to know, like, you know, I know there's a question about mask mandates and other things. We would love to have these really simple causal stories to tell, because that makes for really good visualization, but oftentimes that doesn't exist. And so if you don't have that simple causal story, what is the right level of complexity to try and show and explain these kind of theories of the case and how they're reflected in the data? That to me has always been very difficult. And we, from the very beginning, people have always wanted to say, like, oh, well, we want to see shutdown measures or mask mandates or, you know, variants of concern, or, you know, all vaccination rates against all these other things. And we want to see these, we want to see it work like clockworks, but it's not normally that simple in these data.
That's exactly right. And there's a quick overload on how many contextual elements can be consumed at a glance for somebody. And so what we often think about in terms of what we're presenting at any given time is that there will be a variant visual. And that visual is really going to focus just on that key topic and pull it forward in either a temporal way or a geographic way. And so you can either get the trend or you can see its geospatial location. And then maybe you link those so that as you move over time, you can see the map change. But at any given moment, you have discrete pieces that you're absorbing as an end user. So, and then separately surfacing, well, what are genomics data? I mean, to Jared's point earlier, I've been utterly amazed to see are not described on the nightly news and epi curves showing up all over the place. And it's pretty remarkable. We aren't there on the genomics data, you know, and, you know, I have a PhD in biology. I've spent more time with those data than anything else. And it's complicated to communicate even within a lab context for people who are actually collecting those. So I think it's also then just surfacing, well, what is the output of that ends up being so useful? It's been interesting to watch, for example, the genomics data coming out of the wastewater treatment systems, where we can start to see those signals pop and how some of that visualization is done. But again, I think sort of narrowing our lens and having discrete different visuals for each one of these different elements has helped a lot, where we're not trying to show it all on a map. We're saying, well, you have your map and your contextual information here. Now here are 6 different ways of looking at it. And sometimes it's as simple as an infographic that just fills up a syringe or fills up, you know, to a threshold line, something like that.
Oh, Jared, did you have you want to
No,
add?
I was just going to say, yeah, infographics have been very popular to do exactly that. The one that I showed wired in sources from 5 different, places into a dynamic infographic. And we've seen a lot of people using a tab-based approach, in their dashboards, or the, like I mentioned before, the bivariate mapping, and maybe coupling a map with a chart on the side and having all the elements interactive. So you click on one geography and all the widgets update, to give you some more detailed information.
Courtney, I know we're running out of time. I just saw that Lloyd had a question that's very dear to our heart at COVID Tracking Project, which was about test positivity rates and the way that they were interpreted and displayed. They're a total mess. We totally agree. And we wrote many things about being cautious with those interpretations, particularly across different jurisdictions. And people do it anyway, and we totally failed in getting people to stop using those metrics. I mean, it's interesting. There's probably some signal there. And so people want to use it because there's a possibility of signal there, right? And I think that's one of those things that's very hard because there's that possibility, but it doesn't always work. It can be complicated to get people to stop using it. And that's all I'll say about that. We have many things on COVID tracking about test positivity if you want to see all the ways it can go awry.
And especially for this audience, I would just flag that those issues are going to be even more front and center as we move into what we expect to be an active flu season. We're going to need to be looking at the intersection between COVID caseload and influenza. They're both, from an immediate symptom perspective, they're both ILIs, influenza-like illnesses. They're going to surface very similarly. We're going to need to be tracking testing for both and vaccination for both. So thinking about how we also move from a very pathogen-specific or disease-specific lens for these dashboards and start expanding our aperture to include a broader public health landscape as we start to see the intersection between these infectious diseases.
Great, thank you all so much, and thank you all for joining, and a big thank you to our awesome panelists. Time is now up, and we hope to see you at the rest of the expo. Bye-bye.
Thank you.